So, I want to start today with a patient profile that I feel like you've probably seen maybe 5 times this week alone in your clinic. It's the
In your blood over 24 hours. With scheduled dosing, say taking naproxen every 12 hours, you are maintaining a steady state. You are keeping the drug levels consistently high to suppress inflammation.
which sounds great for the knee.
Great for the knee, but just terrible for the stomach lining. That steady state means the mucosal defense mechanisms in the gut never get a break.
Right, it's a relentless assault on the prostaglandins.
Exactly. By keeping the dosing strictly PRN, you are naturally creating valleys in that graph. You are limiting the total medication exposure. You're shrinking the area under the curve.
So you're essentially giving the gut a holiday.
A holiday, yes. If a patient only has pain 3 days a week or maybe only for a few hours after gardening, why expose them to a 24-hour steady state of toxicity? You're buying safety by reducing exposure.
That makes total sense. And then you mentioned physiology.
Right, we're talking about flare-ups here. By definition, these are intermittent spikes in inflammation and pain on top of a baseline. It aligns logically to treat the spike when it occurs, rather than treating a baseline that might not actually require that level of intervention.
And finally, there's the autonomy piece, which I assume is about empowering the patient.
It is. It allows the patient to navigate their daily life based on their actual experience.
Yeah.
If they have a quiet day, they take nothing.
But if they have a busy day on their feet, they treat the symptoms.
Right. It turns the patient into an active participant in their management rather than a passive recipient of a rigid schedule.
That all sounds very sound. It's incredibly logical. But here is where it gets sticky for me when I'm in the clinic. We have to ask, does scheduled dosing actually work better?
Ah, the efficacy question.
Yeah, if we ignore the side effects for a second, is the pain relief superior? Because if I'm the patient and I'm hurting, I don't care about the area under the curve. I care about walking to my mailbox.
This is the surprising part. The evidence verdict is actually mixed. Yes, scheduled dosing does improve symptoms compared to placebo or sporadic use, but the improvement is generally described as modest.
Modest, that's not exactly a ringing endorsement for prescribing around the clock.
It isn't. We aren't seeing a night and day transformation in pain scores for the average patient just by switching to a schedule.
So when you do the risk-benefit analysis for the majority of patients, that modest benefit in symptom control is simply not strong enough to justify the increased risk of a GI bleed.
Correct. That is why the guidelines generally land on starting with as-needed dosing. It's the defensive safe play.
However, and this is massive, however, we all have those patients where the defensive play fails.
Yes, we do.
The patients who call back a week later and say, "Doc, this isn't touching it. I can't even get out of a chair."
And that is where we have to pivot.
Yeah.
We have to discuss when as needed becomes insufficient, because there are specific patient profiles where reliance on PRN dosing is actually a failure of management.
Let's profile those patients. Who are they?
The first group is what we might call the frequent flyers regarding flare-ups. If a patient is having flare-ups that are frequent and predictable, PRN dosing can leave them in a cycle of constant catch-up.
This is the chasing the pain phenomenon I've heard about.
Exactly. Think of it like a forest fire.
Okay, I'm listening.
As-needed dosing in a high-frequency patient is like waiting until you see 50-foot flames before you call the fire department.
By the time the trucks arrive, the house is gone.
Or in this case, by the time the NSAID reaches peak plasma concentration, the fire has already jumped the brake line.
You're playing catch-up.
You're clinically behind. The inflammatory cascade is self-perpetuating. Once those cytokines are raging, it takes a much higher dose and a longer time to bring them back down than it would have taken to keep them suppressed in the first place.
So for these patients, the gap between symptom onset and relief leads to significant suffering.
Right. And it's not just about pain scores either. It's about function.
That is the critical distinction we need to make here. We aren't just treating a number on a 1 to 10 scale.
No, we are treating the inability to walk to the mailbox, the inability to work, the inability to get down on the floor and play with grandchildren.
So if the fire is stopping them from living their life, we need a different strategy.
Exactly. If the flare-ups are causing significant functional limitations, where the patient literally shuts down their activity, relying solely on as-needed dosing can be detrimental.
Yeah.
In those cases, the consistency of scheduled dosing can flatten those spikes and maintain function.
There's also a psychological component here regarding adherence. I've had patients who tell me, if you tell me to take it when I hurt, I'll wait until I'm crying because I don't like taking pills.
I hear that all the time.
But if you tell me to take it at 8 a.m. and 8 p.m., like a strict prescription, I'll do it.
That's a very real factor.
Yeah.
Patient preference and adherence styles matter a lot. Some patients crave the predictability of a schedule.
It reduces the cognitive load of deciding, is it bad enough yet? Should I take it now or wait an hour?
Precisely. If a patient strongly savors scheduled dosing for better management, and we see that it improves their adherence to the overall treatment plan, it's reasonable to respect that choice.
And this is the crucial, but we can only respect that choice if we've cleared the safety hurdles.
Absolutely. We can't just put everyone on scheduled dosing because they prefer the routine.
Which leads us to the decision matrix. How do we actually make this call in the clinic? It's not a coin flip. There are variables we have to weigh.
Let's break down that matrix.
Okay, what is the first filter? The gatekeeper.
The gatekeeper is undoubtedly gastrointestinal risk. This is the non-negotiable variable. Scheduled dosing is reasonable only if the patient has a low GI risk profile.
So we're checking the history, no ulcers, no history of GI bleeds. What about age?
Age is a major factor. The elderly are inherently at higher risk. The stomach lining thins, defense mechanisms weaken.
So if you have an older patient or someone with a history of peptic ulcer disease, scheduled oral dosing becomes a high-risk gamble.
In those cases, the gate remains closed.
Okay, so if they pass the GI risk test, they're low risk. Then we look at the second variable, symptom frequency and severity.
Right. High frequency justifies high exposure. If the symptoms are constant or near constant during a flare, the as-needed approach essentially becomes scheduled dosing anyway,
Yeah.
just less organized.
So we formalize it to get ahead of the pain.
Formalize it, yes.
Now I want to throw a wrench in the gears here. What if we have a patient who has high-frequency symptoms, so they really need the schedule, but they have moderate GI risk? Maybe they're 70 years old or they have a bit of reflux history.
That's a tough spot.
We're stuck, right? We can't schedule the oral meds safely, but PRN isn't working. Is there a third door?
There is. And honestly, it's a door we should probably be opening way more often in primary care. We need to talk about topical NSAIDs.
Diclofenac gel.
Exactly.
Yeah.
Topicals are the perfect middle ground or adjunct.
I feel like a lot of patients, and honestly some clinicians, think of topicals as just a muscle rub, like it's a distraction or a placebo. Does it actually get deep into the joint?
It absolutely does. The pharmacokinetics are fascinating here. Topicals penetrate the skin and get directly into the synovial fluid and the soft tissues around the knee joint.
Okay.
But here is the magic trick. The systemic absorption, the amount that gets into the blood and travels to the stomach, is a fraction of what you get with oral pills.
So you get the drug where you need it, the knee, but you bypass the organ you're trying to protect, the stomach.
Precisely. You are decoupling the efficacy from this systemic toxicity.
So for that patient we just described, moderate GI risk but frequent pain, this is the answer.
It allows you to maintain symptom relief while keeping the systemic risk incredibly low.
So in our matrix, if the GI risk is elevated, we shift to topicals immediately.
That should be the reflex. It's a vital tool to keep in the rotation either as an alternative to oral meds or as an adjunct to minimize the oral dose needed.
Okay, let's be crystal clear about the red lights. When should we explicitly avoid scheduled dosing? We mentioned GI history. What about the severity of the arthritis itself?
We need to be really careful there. The guidance we are discussing applies to mild to moderate knee osteoarthritis.
Right.
If a patient has severe osteoarthritis, we're talking bone-on-bone, end-stage disease scheduled, NSAIDs are often not the answer.
Because the mechanism of pain is different.
Partly, but also because of the ceiling effect. In severe mechanical bone-on-bone pain, inflammation isn't the only driver.
So pushing the NSAID dose to the limit simply increases toxicity without yielding better function.
Exactly, you're flogging a dead horse.
And obviously, patients with high comorbidities, kidney issues, cardiovascular risks, they should generally avoid scheduled NSAID regimen.
Oh, absolutely. If you have a patient with stage 3 CKD or heart failure, you do not want them on a scheduled NSAID. The fluid retention and renal load are just way too high.
Okay, so to recap the matrix for our listeners, check GI risk first. If low, assess frequency and function. If high frequency, consider scheduled dosing. If GI risk is present, stick to PRN or use topicals. And if the above is severe, don't expect miracles from dosing schedules.
That's the framework right there.
Now I want to talk about where we go wrong, the pitfalls. Because even with a solid matrix, it's easy to slip up in a busy clinic. What are the major don'ts here?
The biggest one is the assumption of efficacy.
Assuming scheduled is just better.
Right. Do not assume that scheduled dosing is universally more effective just because it's more medication. As we discussed, the data shows the benefit is modest.
So don't promise the patient that switching to a schedule will cure their pain. You just set yourself up for failure.
Exactly. Managing expectations is key.
What about how we measure success? I feel like we get fixated on the pain scale. You know, what's your number 1 to 10?
That's a very common trap. Don't base dosing decisions solely on pain scores. We need to treat the whole patient.
Don't ignore function.
Yes. If the patient is walking better and doing more with PRN dosing, even if they report some pain, that might be a win.
Conversely, if scheduled dosing lowers the pain score, but they are experiencing dyspepsia or fluid retention, you've lost the battle.
You've traded a symptom for a side effect.
And we touched on this, but it bears repeating, don't extrapolate.
Right. Do not apply these findings to other types of arthritis, like rheumatoid arthritis.
Because RA is an autoimmune systemic fire.
You have to treat that with scheduled disease-modifying agents. This specific guidance is tailored only for mild to moderate knee OA flares.
There's one more don't that I think is arguably the most important. Don't forget the context.
Never overlook non-pharmacologic therapies.
We can get so deep into the weeds of dosing schedules, pills versus gels versus injections that we completely forget to emphasize weight loss, physical therapy, and lifestyle modification.
The NSAID is just the scaffolding.
Exactly. It's the scaffolding to help the patient do the hard work of lifestyle change. If they aren't doing the PT or working on the weight, the NSAID is just a Band-Aid on a bullet hole.
Well said. And finally, quality of life.
Yes. Don't assume a massive jump in quality of life solely from a scheduling change.
The research suggests that while symptoms might improve, the overall quality of life metrics don't always skyrocket. It's nuanced. We have to be realistic with our patients.
This has been a really helpful breakdown. It takes something you do 10 times a day, writing an NSAID script, and adds a layer of precision to it. It stops it from being just a reflex and makes it an active decision.
It forces us to be intentional, and that's really the goal of all of this.
So let's wrap this up with a synthesis. If you had to give the listener a golden rule for NSAID dosing in knee OA flare-ups, something they can take to the clinic tomorrow morning, what is it?
The golden rule is this. Start with as-needed dosing for mild to moderate knee OA flares. That is your baseline to prioritize safety and minimize GI toxicity.
But stay flexible.
Exactly, however, do not be rigid. Reserve scheduled dosing for those specific patients who have frequent function-limiting symptoms and a low GI risk profile.
And always make that decision with the patient, not for the patient.
Always shared decision-making is paramount.
Start safe, escalate logically, and check the GI risk at the door. Now, before we sign off, I want to leave the listeners with something to chew on. We've talked about the clear-cut cases, the low risk and the high risk, but clinical practice is rarely black and white.
That's very true. The thought I'd leave you with is about the gray zone.
The messy middle.
Right. We know what to do for the healthy 50-year-old, scheduled might be totally fine, and the ulcer-prone 80-year-old, definitely PRN.
But how do we navigate the conversation with the patient in the middle? The 68-year-old with moderate risk who demands scheduled dosing because they just want to be comfortable.
That is the hardest room to be in.
It really is. It highlights that medicine isn't just about pharmacology. It's about negotiation and risk communication.
How do you explain to a patient that you are withholding the comfort of a schedule because of a statistical risk of a bleed they haven't experienced yet?
That conversation, managing the patient's desire for immediate relief against our responsibility to prevent future harm, is where the real art of medicine happens. It's not in the prescription pad, it's in the explanation.
A great reminder that the soft skills are often the hardest part of the job.